Well, good morning, everyone, or almost good afternoon. I'm Dr. Lena Wen, and I'd like to welcome you all to our panel discussion that has a rather striking title, which is Code Blue, Can Maryland's Hospitals Keep Delivering for Everyone? So as you all know, here in Maryland, we're fortunate to have some of our best hospitals and also a unique all-payer global budgeting system that has long been viewed as a national model. But at the same time, there are distinctive challenges facing us now in the context of a changing federal climate, rising costs of care, and also an overburdened workforce. And so, are we really in a code blue? And how can our hospitals continue to deliver high-quality care for all Marylanders? And so for this conversation, we're joined by 4 of our top healthcare leaders in the country. I could spend a lot of time introducing them, but in the interest of time, I will not. And instead, I'm going to go straight into our questions. And our first question I want to pose to Mohan. I wanted to start with you. If you can name some of the major challenges that are top of mind for you as a hospital CEO here in our region.
Sure. So as you referenced, the uniqueness of the reimbursement model in the state of Maryland is predicated on a model that's different than the rest of the country. And that model has a long history. That history includes the recognition that now in 1970s, the state of Maryland lived under a model where there's a relationship between the federal government and the state of Maryland that attempted to address the issues of ensuring access to health care and managing the cost, the rising costs of health care. So those concepts of access and cost are really form the foundations of the history of the model that has defined Maryland's reimbursement system for now going on 5 decades. In 2014, with the passage of the Affordable Care Act preceding it, the state of Maryland and the federal government moved away from volume-based reimbursement to value-based reimbursement that was consistent with what the federal government aspired to achieve with the Affordable Care Act. And so we will argue that the state of Maryland, regardless of anyone's politics, moved further and faster to value-based health care than the rest of the nation. We now stand at a point in our collective history where the state of Maryland is engaging with the federal government in a negotiation for what the future of this model looks like. And suffice it to say that there's, I'll say, a high level of concern and anxiety associated with that conversation, both from the position of how that negotiation is going between the state of Maryland and the federal government, but I would argue, far more importantly, how the current model is actually operationalized within the state, and do we as hospitals believe that we can continue to deliver on those ideas of ensuring access to high-quality health care at a cost, while managing costs with the expectation that we are going to grow at a level lower than the national rate of growth in healthcare. So for us, at the medical system, we worry very much about whether the model is a sustainable model. It is predicated on an all-payer construct that is now being challenged at the federal level. And we believe that there is opportunity with the tools that exist in the model today for the regulators to align with the healthcare industry in a way that ensures we can continue to drive access for citizens across the state of Maryland.
So I'm sure that our audience will have many questions for our panelists as well. I have my phone. I will be checking for the audience questions as we go through this presentation. We won't have a separate Q&A for questions, and so feel free to put in your questions along the way. But I wanted to turn to you, Brad. Do you agree with what Mohan said, or are there other headwinds that are also challenging you and MedStar at the moment?
I mean, Mohan summarized, summarized it very well in terms of the concerns that the industry has as we've entered into this next phase of the evolution of the waiver. And I focus on the term evolution because with any model, you want a model that is adaptable, has flexibility, and also meets the needs of the changing environment that you're in. And so For us in the healthcare industry in Maryland, we look for those factors and we look to work with our regulators to make sure that we can keep up with inflationary costs. We can keep up with changes in supply chain and changes in technology, but also providing a stable environment for the workforce. A key to this really is in ensuring that we have a stable workforce of providers across the spectrum to meet those access needs. And as the model has evolved, there have been challenges at times in terms of how the industry is working with our regulators to address that.
I wanted to turn to you also, Kevin, to weigh in here, and specifically to address the title of our panel, which I think may be striking to some as Code Blue, right? Do you think that we are in this existential stage right now, or how would you rate the problems that we're facing and the impacts that it could have on healthcare?
So, Lena, as an old nurse, I was taught a long time ago, during a code, you always take your own pulse first. And I think we are at a moment where we need to take our own pulse first. And the reason I say that is because it's not just Maryland hospitals that are going to be challenged, it's hospitals across the country. As you look at the proposed changes to Medicaid, I'm very concerned about vulnerable populations that are going to drop off of the Medicaid enrollee list that really do need access to care, that will lose access to care, will either not get access, will die at home, and or show up in our emergency room requiring a lot more resources than they would have if they would have gotten access on the front end. And so from that aspect, I don't worry just about what's going to happen to Maryland hospitals, but what's going to happen to healthcare in this nation. If you also look, excuse me, at the projections, the only thing that's projected to grow over the next 10 years is actually tertiary and quaternary care, and that's because of the aging of the baby boomers. Community hospital growth will remain pretty flat across the nation. That's the projections. And as you start to think about the cost structure, and you look at the pipeline of gene therapy and cellular therapy that's out there, that, by the way, is life-saving for many diseases, but can run anywhere from $2 to $5 million per treatment. And then you look at innovation in the medical devices and the cost of medical devices that we're seeing. I see a cost structure that's going to impact employers' benefit plans in a way, and the literature shows right now, during this time, we're starting to see double-digit increases in employer benefit plans, both from an employer perspective and also an employee perspective. So I think the entire system is reaching a point where it could be Code Blue, but I think we have to step back and become even more innovative of how we're going to use all of the tools that are now evolving, everything from AI that was being spoken about, to new technology to advance what we're going to be able to do in the delivery of healthcare in this nation.
You surfaced a lot of issues that I'm sure we'll get to, because I'm seeing some of the audience questions come through that actually touch upon some of the areas you mentioned. But before I get to some of your great questions, Emily, what are the main issues that you and Kaiser Permanente are tracking? And how are you also thinking about meeting the members or meeting the needs of your members?
Yeah, thank you. As a payer-provider organization, I think about it in a little bit of a different lens. We certainly want to ensure that Marylanders have access to health care, but also access to coverage. And Kevin touched on this a little bit, and we think a lot about the stability and the sustainability of our Medicare Advantage programs in the state of Maryland. And those are important for some of our most vulnerable seniors. And how do we assure that those are programs that are available to our community? And they're important because Medicare Advantage across the nation typically has lower out-of-pocket payments, provides coverage for supplemental benefits, dental, vision, and to Kevin's point, prescription drug coverage. And so for many seniors, without those benefits, they will lose access not only to their coverage, but to care. And so we think a lot about, from the payer perspective, how these regulatory changes will impact the state. We also think that in terms of, being part of the solution as an integrated caring coverage system, we can help be part of the solution. Kaiser Permanente does not operate hospitals in the state of Maryland. I rely on my esteemed colleagues to provide that care, but we do provide a lot of care outside of the hospitals. And so how do we think about prevention and providing care in a low-cost setting so that, the acute care is available to those who need it?
So I'm going to stay with you for a minute, Emily, because we've had a number of questions centered around cost of care, in particular around medications. Somebody's asking in particular about pharmacy benefit managers and how they've been under scrutiny on the Hill and in the public discourse. And so can you talk about prescription drug costs and how your organization is thinking about it, but I guess more globally, how we should think about what changes might be on the way or not to make drugs more affordable for patients?
Yeah, I wish I had all of those answers. I would be on a different panel, I think. But, Kevin touched on, it's definitely, I think all of us are experiencing, high double-digit increases in prescription drugs and, many life-saving treatments that we want to have available for our members and for our patients within the state of Maryland. And so again, I think for Kaiser Permanente, it's all about focusing on prevention and early disease detection, and in many instances, that prevention and quality care leads to affordability. And so the earlier that we can identify these needs, the less we need some of these very expensive treatments later in members' care.
That's a great point. Thank you. We've also had a number of questions around workforce, and I know, Brad, this is something that you had mentioned in your comments earlier. Let me read this comment. Canada is actively recruiting U.S. healthcare workers to address its own staffing shortages, especially trying to entice workers who are not pleased with the current administrations. Are you aware of Maryland hospitals losing some of their workforce to Canada? And I would add also to this, what might be some strategies that are important for retaining a healthcare workforce in today's climate?
Yeah, I'm not aware of any health providers in the state of Maryland going across the border. But I would say really for the industry, our greatest strength and our greatest asset is our people. And investing in the development of your people is really what every health system and hospital in the state of Maryland is trying to do. How you grow a pipeline, partnering with higher education, partnering with community colleges to create pipelines for entry-level clinical positions, establishing wellness and well-being programs for your providers so that they have an outlet. It is a demanding job. Working a 12-hour shift, working a 10-hour shift. Some of the demands that our frontline clinical workers are dealing in terms of the daily interactions. You have to create an entire encompassing environment for them. It's not always about pay, it's about the environment, and you also have to provide those growth opportunities. And I think collectively here in the state of Maryland, we've done a good job of creating the right focus and lens around protecting the workforce within Maryland's hospitals, but also growing that workforce.
Thank you. Mohan, let me address this next question for you because you had mentioned the work around value-based care, and this is why the Maryland's global budgeting model was initially established to try to incentivize value-based care and population health. And so can you give some examples of how you are leveraging that model to invest in community health that reduces long-term cost, but also improve outcomes?
Sure. In the state of Maryland, there is absolute incentive built into the model to decrease what is described as potentially avoidable utilization. That whole idea is to say that if we do better jobs of managing patients with chronic disease, such as hypertension, diabetes, asthma, if we do a better job of managing those patients and preventing them from requiring the resources of an acute care hospital setting by getting upstream and investing in primary care in communities, that incentive is built into the model. And I think all of us have plenty of examples of where we have very purposefully gone upstream, invested in primary care to help reduce the need for hospital-based utilization in terms of the entire care continuum. One thing I would say to Brad's point about workforce that I think is worth calling out, while we have not seen our workforce heading to Canada, the reality of our physician workforce here in the state of Maryland are constantly under challenge when it comes to how physicians are reimbursed in the state of Maryland compared to the nation. And when you're in the bottom decile for physician reimbursement in a competitive landscape like the Mid-Atlantic, that does become a real challenge for our workforce. When you think about the academic mission of medicine in our health system and in others, when you think about what's required to invest in innovation, on previous panels you heard my colleagues, Dr. Gerald, Dean Gladwin, you heard Ron Daniels from Hopkins talk about the need to invest in resources in innovation to be able to get upstream on many of these challenges. That requires the resources have to come from health system delivery performance. And so that alignment is a critical alignment when you think about workforce challenges, whether it be in academic medicine, whether it be in physicians, or whether it be in our global workforce overall.
Building on that investment point, Kevin, I'm going to direct this audience question to you, but all of you feel free to jump in if you would like as well. The question is, given all the challenges that your organizations are facing, what are you doing to invest in growing your leaders? And what are you investing in? What are you doing to invest in growing your leaders? And so feel free to take that from any standpoint, whether it's nursing workforce or administrators or other leaders.
So I would say the following to that. First of all, succession planning for our organizations is incredibly important. It's hard for me to say this, but I'm not going to look at anybody else on the stage, but people who grew up my age and have been in healthcare over 40 years, we learned how to do what we do today in terms of leading large organizations because we had to do it because there weren't health systems when we first began our jobs. The next generation that comes behind us did not have that experience. As health systems formed, corporate services were developed and things like managed care contracting, the treasurer's office, the comptroller, all of that moved to a corporate level where your entity leaders really don't have much interaction or knowledge of how to interact and really run a system. And so for us at Hopkins, I've spent a lot of time with the next level down of leaders, really developing them and making sure that they understand the broad spectrum of what they need to know, everything from med-mal to what the comptroller's role is and how you use the comptroller, to managed care contracting, to every aspect of running the organization from patient safety and quality, all of those aspects to assure that as they evolve and think about their next growth in leading a health system, that they're prepared to think about all of those elements. Because if you talk to anyone who's recruiting for positions like many of us sitting on this stage today, they will tell you that's one of the missing elements in the next generation is they don't have all of those experiences. And boards are having to make difficult decisions around what they're willing to live with and live without. And that's a challenge that I see for the industry ahead in terms of from a leadership perspective.
Many people had questions touching on population health or public health or social determinants of health. And so as we wrap up, as our time is very limited today, I'm going to be asking each of you, starting with Brad, about the programs that you're the most proud of initiatives that you want to share that help the most vulnerable, that strengthen community partnerships, or that move the needle on population health?
Yeah, within the MedStar Health System, we established a food RX program a few years ago as we did our community health needs assessment. And high level, at 4 of our hospitals in Baltimore, we have a food pharmacy where we have partnered with entities like the Maryland Food Bank to identify food insecurities that patients have coming in. And they are screened up front through their providers. A script is written for those patients for a certain period of time, and we've actually been able to document better health outcomes for those patients moving forward.
Yeah, so I would say, for Kaiser Permanente, it's really who we are. I mean, we have 80 years of really being integrated in population health, but I would say over the past couple of years, some things that we've really invested in are our community health workers and really thinking about the care team and having that community health worker being an integral part of the care team in the community, helping our members with not only their health, but the things that impact their health, food insecurities, housing insecurities, mental health issues, and so really expanding our care team to bring in the community for our members.
Mohan and I worked on a paper together with our teams around population health. And one of the amazing statistics is in the city of Baltimore, 33,000 people drive greater than 50% of the healthcare spend in the city. 33,000 people. When you start to break that down and look at by zip code, one of the projects we took on with some of our peers across the city was we recognized that there was a trend in people who were homeless and being high utilizers of our emergency room and hospital days. And we studied a program that was in another part of the country where they were putting people in homes and showing statistical differences in how people decrease their use of the ER and decrease the use of the hospital just by being in a home setting. Now, there were wraparound services, and we continue that today. We now have over 200 homeless people that we sponsor and put in homes to make sure that they have good health access to good health care, but also better health outcomes in terms of using our emergency room and our hospital for levels of care that aren't required in a hospital setting. But the importance of just some basic needs like food and home really do impact health outcomes.
So for us, we have been very purposeful in trying to describe our responsibility of being anchor institutions within all of the communities that we're blessed to serve. And we're not talking about access to acute health care when we describe anchor responsibilities. It is to describe ourselves and demonstrate that we are vibrant members of a collective community. When we think about social determinants of health, how we have very purposefully invested in workforce development within our communities is a very tangible example. When we think of how we've partnered with educational institutions from elementary school on forward in some of our most historically disadvantaged communities, parts of our community, we're very purposeful in those investments. Impact investing for our organization over the last 5 years, 4 years now, was a new concept to our organization, and now being able to invest very purposefully in economic vibrancy within our communities, all the way from the Eastern Shore to Southern Maryland to Prince George's County to Hartford County, and notably in Baltimore City, are all examples of how we think about being purposeful in having our footprint impact the health and wellness of communities.
Thank you all for that candid and very thoughtful conversation. It's clear that we can continue speaking for quite a bit longer, but in the interest of time, I hope that you'll join me in thanking our hospital leaders for all they're doing for the state of Maryland. Thank you.